of the potential mutations that sticks out in my mind that may be a little bit more controversial in terms of the role of even single agent IO is KRAS G12c. And I'm going to put you both on the hot seat with an unfair question. So, I think you're right. We have this retrospective data with EGFR and ALK. We have, some of the early stages in second line immunotherapy showing that immunotherapy is probably inferior to docetaxel for some of these mutations, subset of patients with mutations, or at least not better. KRAS G12c has immunogenicity, and it is a mutation that we think may be susceptible to immunotherapeutic approaches. And just given the new approval of sotorasib, a targeted therapy approved in second line, I'm going to ask again an unfair question. If you had a patient with a KRAS G12c who is a heavy smoker and had a PDL1 of 90%, and here is the true convergence, I think, of IO and targeted therapy in this specific genotype, would you give single agent pembro, or would you, we're going to talk about chemo IO in a second, but the options on this multiple choice question are KRAS G12C fit, high PDL1, heavy smoker. You've got pembrolizumab, Keytruda, or sotorasib as options. What would you give first? Zosha, I'll let you take and there's of course probably no right answer here. But I put this question out because I think this is the mutation where we're wrestling with what to do. So what would you do in this case?
I think it's a really interesting scenario, and we're actually facing this in the clinic now. I think you're exactly right that the KRAS G12C mutations tend to occur, in patients. One other factor that goes into it is smoking history, and we know that heavier smoking history tends to correlate with better chances of response to immunotherapy. And so I think, that may be another factor to play into it. I think, right now sotorasib is approved as a second line and later therapy. So, I tend to think of it as a second line treatment option, because also, as you guys might have talked about earlier today, the responses and the duration of response to sotorasib are good, but they're not quite as high as we're used to seeing for EGFR and ALK and other mutations. So for a patient, newly diagnosed with KRAS, I think of it as my second line option that I'll keep in my back pocket. In a case like this, I think, particularly if the patient did have a significant smoking history, did have high PDL1, I think single agent pembrolizumab, Keytruda would be a reasonable option. And frankly, I might lean towards that. I think just one other point that, again, maybe we'll get into is one of the reasons we're cautious with some treatments like EGFR targeted therapies is because we know that introducing a drug like osimertinib or Tagrisso after immunotherapy can lead to sometimes higher rates of side effects from the Tagrisso after immunotherapy. And I think we don't know that yet for sotorasib. So that's something we're going to have to be, we're going to have to learn about and see it, but we don't know that to be the case yet. So I think for a patient like that, if I had to choose, it would obviously be a discussion with the patient about what their preferences are, but I might lean towards Keytruda. Okay. I don't know what you guys both think.
Jack, your thoughts?
I agree. I think that, sotorasib is a very, very welcome addition to our armamentarium. But I think that, we do have a range of efficacy for our targeted therapies, and sotorasib and amivantamab for exon 20 are, very useful tools, but I don't think they're in the range that should supplant first-line therapies based both on the lack of data and on what we've seen so far to expect. I think that it's much less of a stretch to move a RET inhibitor up front with response rates of 60% or higher. Anytime you're north of 50, 60% and getting durations, median progression-free survivals of approaching or exceeding a year, that's not a leap to me in the way that I think it would be. Much more of a leap to leapfrog a therapy with a 30 or 40% response rate into the first line setting. And in addition, there is a very real potential that immunotherapy alone or combined with chemo can be associated with phenomenal efficacy in a KRAS mutation positive in a little way that's different from what we expect from EGFR ALK, where it's almost mutually exclusive, or there's a yin yang of the more we can be hopeful about the targeted therapy, the less we can be hopeful about immunotherapy. I don't think we can say that about BRAF or KRAS, where if I had a patient smoking history, KRAS, and high PDL1, I would be very optimistic that they could be a sensational responder to immunotherapy. I would be inclined, if someone doesn't have a lot of cancer-related symptoms, not a huge tumor burden, and I feel like they could progress and still be candidates for anything else after that without being in a wheelchair, I would be inclined to ask, what's the least we need to do to potentially get a sustained phenomenal benefit? And if they can be a big winner with IO monotherapy, I would hope for that and still leave everything else available. I wouldn't hesitate to do chemo IO, for instance, for someone who's losing weight every visit and escalating pain, and somebody who's giving me signals that we need to front load or lose our chance. But if otherwise, I don't want to saddle anyone with more treatment than they need and potentially give someone gratuitous maintenance pemetrexed, Alimta, if the IO is doing the heavy lifting. I don't want to give any chemo as, shark repellent that isn't really doing the job. And so this is one of those situations where there is plenty of room for judgment and nuance and not really data yet, which is fair, at least because you've got plenty of room for patient preference and your own judgment. But I land right where Zosia is here.
Yeah, I'll make it. I'll create some consistency here. I agree. I think patients with a high, BRAF and KRAS G12c, a BRAF V600E mutation and a KRAS G12c mutation, those are considerations in my mind to consider immunotherapy frontline. KRAS G12c, we don't have an option yet, but in BRAF V600E we do. We can use targeted therapies first, but I think single agent Pembro would be the way that I go as well. There's a real chance for durability. There's a tail of the curve. We've had some nice 5-year outcomes from the Keynote 024 study recently published. And I would go that way. I think one of the things that Zosia said is important is we don't know yet this whole toxicity story about sequencing immunotherapy followed by targeted therapy, specifically for KRAS G12c. We've learned with EGFR that if you potentially start with immunotherapy and then sequence them to Tagrisso, there may be real toxicities as it relates to pneumonitis. So I think that we're clearly, we're still learning. We've got a lot to learn here, but I think hopefully can have some of these questions answered in the next few years.